Well, good afternoon. I would like to say that U of H is playing tonight as well. I'm not a Cougar, but I have to talk about my hometown. So thank you for having me. I know if you were here last year, you were going to see some similar slides. We have added a few. I promise my 120-odd slides will not go more than an hour and 15 minutes. A lot of them are just flip-throughs and being able to give you some information. So we have the standard disclosure statement. And then really the objectives is to explain our quality and patient safety at Memorial Hermann, how we're really on that journey. I feel like a never-ending journey for high reliability. Really how our physician leadership commitment is moving forward, and we're actually expanding that a lot as well. And then looking at some MACRA and MIPS and all of our favorite stuff from our federal government and how we have to comply with that. So everything is bigger in Texas. If you haven't visited, we have a very large area to cover in Houston. On this map, the Grand Parkway is still dotted. Actually, it is finished, and it has cut my time to the airport by half, so I love it. But we have 3 loops now, so we have a lot going on. We have the largest Texas medical center, over 20 some odd locations just in a very small area down in the medical center, and a lot of buildings have been torn down and new built. Baylor is actually building another one right now next to the VA. So a lot going on in the medical center. One of our campuses is located in this area. If you want to look at it from the perspective of land, Texas is big. I actually am from far west Texas, about 3 hours from the border of New Mexico, Arizona area, and it's about a 14-hour drive from tip to tip. So it's very large. So when we say we like to drive in Texas because we have to. We have a very large network. I'm not going to read through all of this, but we have $6.6 billion in total assets, over 26,000 employees, 17 hospitals, 2 micro hospitals. We have the market share about 26% right now, although we are competing with HCA at this point because they keep buying up hospitals in our area. We have over 2,000 ACO physicians, and then the list goes on. So a lot of specialties. We have inpatient, we have rehab. Our ambulatory space is growing a lot, and we are really putting a lot of effort into the quality for our ambulatory space as well. This is really kind of our work that we do. So we have our health plan, we have our employer solutions. We've partnered with Walmart in our area, Dakin. We have a lot of employee clinics within those businesses. And then we have our system. We are partnered with UT Health. And then we have our medical group and our MHMD, our physician network, and then also our accountable care organization, which does fairly well every year. So our mission statement and why are we here? So this is the interesting part. I'm in regulatory, so this is required. A mission statement is required. So we look at CMS and Joint Commission, they say we have to have it. So I like this depiction because really, does anybody really remember the mission statement and our values? And we all have to kind of go, okay, what's on our badge when regulatory comes? So really, why are we here? And I think it's a good question because we have to take our mission statement and make it meaningful for our frontline staff. So that is really the goal. So how do we get that done? So we really look at our advanced strategies. That is our strategic framework that we use. The first 2 is to align with physicians and deliver highly reliable care. And then we have others, the value, achieve, but really in general, we have to dedicate our time and effort to the care and aligning with our physicians. We have to be patient-centric. We say that a lot, but are we really doing it? That's the question, and how do we get there? So with that alignment, we took about 3 years ago, and we are doing specific initiatives to that framework, and it's very detailed. We start at the top like every strategic plan does, but then we push it all the way down to the hospitals, and they have to give us specifics on what their strategies are for the 3 to 5 years. It's been a little rough in the last couple of years. We had some layoffs about 2.5 years ago. About 400 to 500 positions, not necessarily all of them were filled. We had a lovely talk about merger, which I'm sure some folks in the room heard about, and then it kind of fizzled out. And so we're just kind of starting our process and looking at, okay, now that some of the noise is gone, what are we going to do with Memorial Hermann in the Houston area? And so with these, we, again, have had our key initiatives. And I'm going to talk a little bit about our clinical care redesign and how that is our goal it started about 2 years ago when we were having some troubles, or we felt like we were getting in that trouble zone as far as our finances were concerned. And we had set a goal for the last 5 years to save $900 million. And today we're sitting right about 450 2 years into it. So this is our structure. Again, this is very similar to if you were here last year, you'll see we're a complex system, not maybe as complex as some, but for the Houston area, it's probably a pretty big space that we have. We have one board, so we have to make sure all of the required information, all of the information gets up to that board level. So we have a lot of different groups, councils that have to meet and to get that information to the board. This is our business, kind of already went over that a little bit. We do have an academic medical center. We have our community acute care centers, hospitals from 90 beds to up to about 500, and then our academic medical center sits about 1,100. We are focusing on our physician enterprise, a strong focus also on ambulatory and moving into our service line structure. We've had service lines, but we haven't really driven by those service lines, so that's what we're working on currently. This is our physician enterprise, our ACO, again, over 2,000 ACO physicians, and a lot of work going on in that space. So we have clinical program committees. This is actually one of the committees that I was most impressed with when I started with Memorial Hermann about 6.5 years ago. And this is a group of committees and councils that are driven by our physicians. They drive the care provided for our physicians and really put us on the path from a best practice standpoint for our hospitals. We have in these committees, these are all the committees we've had. We just restructured in 2019. There were more prior to this, and we have consolidated. It's very small, but primary care, inpatient hospital-based, hospital medicine, CV, cardiovascular, and our CV surgery programs, surgery, clinical services, and then clinical compliance, and we have some that meet occasionally or as needed. And really, this drives the care that our physicians practice under. Our clinical programs approve all of our protocols. They approve what vendors we're going to go with if it impacts our physicians. On these councils, we have hospital leadership, we have nursing, but it is driven by the physicians, and they are the voting members. So with this, our physician leadership for our system, we have about 150 leaders, and this is probably a little dated. We actually probably have more today that sit across all of our committees within our organization. So we really do feel that our physicians are leaders that help us drive to where we want to be, and they actually help us get more to that patient-centered care because they help take care of our patients every day. So in quality, we centralized in 2011. At that time, we had 11 hospitals, and we took all of the quality folks and dedicated resources from the hospitals to the central office. And then we actually redeployed them under the central model back to the hospitals. And so they still, some of them still sit there, but we have centralized a lot of the functions. So we really focused on performance improvement, that robust performance improvement, core measures at the time, although that has gotten a lot less now, patient safety, and then registry. We have a pretty big registry utilization in our organization. And then people, process, technology, and resources. Those were our main focus, what we needed to understand and make sure that we were deploying the right people, processes, and technology to the organization. So our organizational structure, a lot of times it is top heavy. If you look at your own organization, you probably try to wonder what's going on. And when we went to that central model, it did, people would say, oh, well, there's that quality enterprise. That's they're taking over the world, because we had 140 people, but most of those were actually at the hospital, and so we've had to figure out how to depict that appropriately when we're giving presentations, because it does look very large. But again, with our layoffs, we actually did remove almost a full upper layer, executive layer. So there was a lot of flattening the organization, and that actually continues today. And so we're starting to get the care to the patient without so many levels to make those decisions. But don't worry, we still have a lot of red tape, a lot, because all those CPCs, sometimes they say everything has to be approved through those CPCs, and there's a lot of them, so it's interesting. Back in 2011, we had a burning platform. We had a patient that actually died from the wrong blood being given, a transfusion reaction. At the time, Dan Welterman was our CEO and president. It was unacceptable to him. That should never have happened. And so they stopped everything and said, okay, we're going to relook at all of this. And we looked at our policies and procedures. We looked at our practices. We looked at physician, nursing, lab, everywhere. We process mapped everything. And so what they came out with is that we did not have one standard way of giving blood. There wasn't a standard process for nursing, which actually surprises me as a nurse, because I always felt like we always gave it the same way. And so they went on a journey to really, actually it was 06, I'm sorry, 2011 is when we did a lot of our training, but in 06 is when it happened. And then they went to the board and said, we have got to stop this. We've got to change our culture for our organization. And doing that, we got the funds basically to train all of our staff on patient safety. So we got leadership, had initiatives. We went to the board. We provided guidance to our quality committee for that oversight. So we had to report out to them, and then we had to find the money for all of this training, because obviously that is non-productive time for our hospitals. And they were like, well, that's great, but how are we going to pay for it? And now we're going to be out of, our budget we're not going to meet our budget, so we have to figure that out. So we did change the way we thought about safety, and Memorial Hermann really looked at this as our core value. So today it is still our core value. Everything we do, we talk about safety. And not to say that we don't pay attention to the financials and to engagement scores and such, but really when we look at all of it, we bring it back to safety. Is it the right thing to do at the right time? And we had to change our behavioral expectations from our leadership all the way down to the frontline staff. And I would love to say that this is complete, but it is still a journey as well. And I think we have pockets of greatness, and we have pockets of people saying, is this really what we're going to do? And then why? So we have to get back to the why, because I think everybody goes into healthcare. We want to help our patients. We were trained to help them, to provide safe care. So there usually is a reason from an organizational standpoint or culture standpoint why people are not doing the right thing. It's usually not because they don't want to. So we did train over 20,000 employees, over 4,000 physicians, and we have safety coaches at every location. And it took almost a little over $18 million to do this over about a 1.5-year time frame. Today we still train our new employee orientation with the same training. It was initially a 4-hour training. We now have it down to 90 minutes in new employee orientation. We pulled about, I think it was 125 frontline staff members and some leaders as well, and they actually developed the toolkit. We didn't say, here it is, go and make it happen. They actually developed it, and I would say that is, if you can always go to your frontline staff, number one, you're going to get what really happens, and I'm not really talking about the directors and managers, I'm really talking about the frontline staff, because I will say, just from a blood event that actually happened about 5 years ago, we went in and we looked at some things, and the directors and managers and even education said, no, that they do it right. You went and talked to the staff, and there were 27 different ways people were managing this particular process. And when we did our flow maps and value stream mapping, I actually had to ask our directors and managers, our educators, to get up and leave the room because they were so upset. I mean, visibly upset. They were in the back going, "That's not what we teach. What are they doing?" You know, but they weren't asking their people what they were doing. And so it's really important to get people involved, and if they're developing it, they actually will follow it. We have red rules as well. There are 3 red rules: patient identification, timeout, 2 provider check. These are non-negotiable. If you do not follow them, there is a formal HR process, but we also look at it from, it's a 2 paths. So it's HR, and then why didn't we do it? What happened? Was there a process issue, or was it just you just didn't want to do it? A lot of times we do find process issues, and then the HR piece kind of goes off and goes a different path. But they do, we do hold everybody accountable to this, including our physicians. So Dr. Shabbat, Michael Shabbat, was our chief quality officer at the time in 2011, and people asked him what his goal was, and he said 0. And what do you think the reaction was in the room? There's no way this is going to happen, right? And so people still laugh about this today, actually. But how do we get there, and how do we get to 0? Because that was our goal. That's what they came up with. That was no more transfusion reactions. And so we really need to look at we went from externally driven to internally driven, getting our frontline staff to do no harm, and doing the right thing for every patient, every time, every day. Safety is a priority. Again, we changed it to our core value. We look at the reliability culture instead of creating a safe culture. So how can we consistently do it, not just do it one time? And then the broader senior leadership support, that was a big piece again. And how do we have our leaders own and manage the culture? And then medical staff. Medical staff own and promote our safety culture. And we do have a lot today that will sit in the OR and stop the line if they see something wrong. Whereas when we first started it, they were a little argumentative. So we really want to get to high reliability like the other organizations out there. So the nuclear aircraft carriers, the average age that's taking care of that nuclear warhead and all the stuff that in that aircraft is 19. So if you tell me that folks that are in the room that have 20 plus years, and there's many of us, that we can't make sure that we're highly reliable in healthcare, it's hard to believe. Now, I do question that would they compare us to aviation and to the nuclear aircraft, because there's a lot of machines involved, right? So we're dealing with people. So we have to look at it differently, but there's definitely an opportunity to have that high reliable care. So some of the resources, I'll flip through this, is the Managing the Unexpected, and this is a really good resource. I actually put this in the information for the program. It's a really easy read, a really good book, and it's very poignant to what happens. We just had an event where a patient got discharged from the ED with a PT T of greater than 200. And we kept asking, and then there was a bad event afterwards. We asked the physician, why did we discharge? What the nursing? And they were like, well, we thought it was a bad result. And so we sit there and we go, okay, well, we really have that reluctance to simplify that interpretation. Well, we can just say it was just, they had hemolyzation, they had whatever it was. They didn't have any IVs going, so we weren't sure there. But it really came down to, well, I really thought it was erroneous, and even they did it twice. So we're like, really, why would you do that? And so it really came down to it. Still surprising today, even though we have all this training and stuff, it's at that moment in time, are we really stopping, thinking about it, and is it accurate? And nursing went right along with it. They didn't try to stop it. We didn't call. There were a lot of things that happened in this particular case, but it was very interesting to me. We do have, this is our building blocks that we use at Memorial Hermann, our strategy. So we have to have that basis for the compliance, because we like to get paid by CMS. And then we have our governing body, and then it moves up to the sharp end of the care and the care given to our patients. So we utilize this in everything that we do. Robust process improvement, I've talked a little bit about that. We use our Lean, Six Sigma, and change management. We just embarked about a year and a half ago with Joint Commission, and we got a grant And we are actually doing what we call bronze level training, and every employee and physician actually gets a base level training in robust process improvement. A lot of it is quality literacy, understanding what we're talking about, why we talk about it, and then there are different levels. So we are really trying to arm every single employee to a little bit of knowledge of what we think about every day and why we do things. So it's an online program that for education, so it goes pretty quickly. So we had to change the standard work, which is the really basis of process improvement. So how do we make sure that it is reliable, that we're a systematic review of that and not just going in with already the actions or the fix that before you even look at what the process is. So our standard work is everything we do every day, and we have to have the culture around that to make sure that we're doing it in the right way every time. The culture is the hardest thing to change. We continue to look at that. So the number one thing our patients want from us is they don't want us to hurt them, they want us to heal them, and they want us to respect them. And do we do that every day? That is the basis of care provided to our patients. It seems really simple, but when you ask your patients what matters to them, it usually isn't about the medical care. It's about their loved one at home that they have to care for. It's about them missing their dog. It's about their kids. They're worried about their kids. It usually isn't about the treatment that they're being provided. That's the side benefit. But when we seriously ask our patients what matters to them, the answers are very shocking. And healthcare leaders don't always ask those questions. IHI actually did a very big push on that, and there are some organizations that instead of the whiteboard having what my goal is for the day, your nurse and all this, it says what matters to you, and the patient gets to fill it out. And then we go, oh, okay, well, it doesn't matter that you have to go through all this treatment. It's when are you getting out of here? And so we need to focus on those. So really answering the questions for the patients. They do expect exceptional outcomes, and we don't always provide those. And so how do we keep our patients safe in the hospital with the zero event harm? And again, zero should be the goal, and not everyone is willing to shoot for zero. The behaviors for our individual groups drive all of this. And so there is science behind it. It isn't, we hope, a lot of people say hope is not a strategy, but the reliable science is there, and we need to use it to help get there. We need to look at our structure, our processes, our culture, our policies and procedures, our technology. All of it plays a role. I think one of the technologies that probably I don't really like a lot is these lovely portable phones that we ask everybody to carry. And our nurses in some locations potentially get in trouble for not answering within a certain time frame, even if they're caring for a patient. So how is that benefiting that patient, but yet we've put that technology in without even asking about it? There's technology today about secure texting. We've implemented that in our organization, where you can actually text a physician results and things, but we can't take orders. So, but they're still sending orders via the text. So how do we embrace our technology, but also do what's right for our patient and not create more havoc for the physicians or the nurses or frustration, because that's ultimately what happens. And then when we have frustration, what do? We find workarounds, right? So the leadership has to reinforce it. We have to build that accountability. Accountability is one of those words that we use a lot. We don't do it very well. And so how do we get that accountability for the performance and expectations? And we do really look at just culture at Memorial Hermann, and we are still working on it because not every area understands that. So with all of this training, what were our results? And so with that, particular to transfusion reactions, we had a lot of adjusted admissions, as you can see. We had adjusted patient days, very large as well. We had over 1 million transfusions within this time frame, and we considered this a never event. We should not have it, and it is actually now a Sentinel event alert and all sorts of stuff with Joint Commission and everybody else. But we wanted to, within that, we did not have any wrong blood given or any transfusion reactions related to that. So we took this further. Why stop at just blood transfusions is what Dr. Shabbat said. So we have put 0 as our goal for many things. Core measures was one of them. It was actually 100%, but for CODIs, we wanted to get down to 0. We're still on that journey, but we are making progress. This is 2015. You can see here through 2016 that we still had 0 CODIs for one particular hospital. I would say that it is more normal to have 0 than it is to not today for CODI, and we continue focusing on this. We standardize our kits with BARD. BARD came in and did in-services. We do a 2-person insertion now from the ED all the way up to the nursing floors, and really looking at how we care for our Foleys afterwards and getting them out quickly. It's the standard bundle that everybody should be looking at. It's not anything new. It's just being consistent in the care. One of the things that we focus on too is that a lot of people want to come in and get all these fancy ways to fix things when we're not even doing the basics. And we always try to get back to the basics because we can't get anywhere if we're not doing the bare minimum. So then we expanded it even more to our patient safety indicators by AHRQ, and we actually said this should be 0. We didn't, people didn't love this, guys. They really didn't. They were like, there's no way, y'all are crazy. And so we are continuing on this path, and we always said, well, what if it was 0? What the outcome for our patients? This is affecting our patients and the care and the expense for our healthcare in general. And so we talked about it a lot, and we then started giving awards out. So we call them 0 awards, and these are, you have to go 12 months without any of these incidences. It is all coded information from our coders and our charts, and we do verify it. So we have about a 3-month lag for verification to make sure that you really did have 12 months. And the hospitals get presented this award by our senior leaders. Chuck Stokes is our current president, sometimes Dr. Shippey, Dr. Shabbat, whoever's available, but it is a top executive that goes out to the hospital and presents this to the hospitals. We thought they would probably go, great, thanks, this is wonderful, and put it in a drawer. No, they have proud walls now of all of these framed, and very excited about them. And when we might be slightly behind on that validation, they're like, where's my award? Where's my award? So it has made a big difference. It's a friendly competition, but it is beneficial, again, to our patients. And so we are really excited that they have continued, and this has been going on a long time, since 2011. We do it every month. So from that time, from 2011 forward through 18, we've given out 349 0 awards to our organizations. The ones that we just added last year, I believe, were the hip and knee surgical site infections. Those were the ones that we didn't get 0 for until just recently. Those were a little harder to obtain. And in fact, I have a committee that I have to go to this week to talk to my orthopedic surgeons of why 0 is possible. Because there are 7 hospitals within our own organization that have had 0, and they're trying to talk me out of 0 as their goal. So we'll see. So really, where's our overall strategic direction going forward? This was 27 in review, a lot going on, 26,000 plus employees, lots of surgeries. We have lots of babies in Houston. So we've had, as you can see, right, this is the pointer. No. So right, there we go. The adult patient safety indicators, this is the one I was talking about where we give 0 awards and we really want 0. So we've had 15 to 17. There were 17 transfusion reactions that awards given for 0. Wound dehiscence, pressure ulcers, incidents of potential VTE, and post-op kidney injury requiring dialysis. So those are a lot of the awards that we gave just in that time frame. We do have life flight, over 3,300 flights for 2017, and we do get awards. We try not to focus on them a lot. Of course, people like them. They put them in their presentations a lot, but it really is about the care, and then this is just the side benefit, honestly. If we're doing the right thing, these should come pretty easily. So Hurricane Harvey hit. We're still recovering. Actually, today there are still houses that have not been fixed. Lots of, I don't know, I'm sure everybody saw a ton of pictures and enough water to last us a lifetime. But we had a lot going on. We had a lot of employees impacted, but yet they still stayed and took care of our patients. And it cost us a lot of money. So it didn't help our bottom line with this. But we've started recovering, and with our clinical care redesign projects, which I'll get into, it is what helped us sustain our improvements and our savings as well. So a lot happened during that time. Just a little bit about our market share. I won't spend a lot of time, but we are at 26.1. HCA is 24.6. Again, they are our competition right now. And I would say probably in the next review period, they probably will get above us a little bit. But what we're focusing on too is the right care in the right area. Does all 17 of our hospitals need to do heart surgery? Probably not. Do we all need to have babies? I mean, there's just different things that they're really focusing on. I would say HCA just put out some interesting information as well, that they are starting to do the same. They have a hospital, which we always, well, I won't say what we called it. They did not own it at the time, but it was not a great hospital out close to where I live in the suburbs. And they are looking at making it just a women's and children's hospital. So that'll be the first in a community area. So what's our formula for success? Our mission, pretty much whatever our competition does, but 6 months later, sometimes we feel like that. So is that really successful? So we have to really look at moving forward and how do we get there. So we have to place our consumers and patients in the center of everything. I've said that a little bit today. We have to have that delivery platform that integrates across all of the continuum. I can't say that that's always been our strong suit at Memorial Hermann. We are definitely moving there and making great progress, but we are probably a little bit behind the game in that perspective. And we have to breed the best for our physicians and for our staff members, and we continue to do that. On top of all of this, we need to reduce our cost. And so we have, that is a huge focus. Like I said, we had a goal of $900 million to save over 5 years, and we are continuing that to meet that goal. Again, we are doing smart growth. We are growing slower than we used to, but we do have some urgent cares. We're really focusing a lot on the ambulatory side. Our convenient care centers has our primary care physicians that has lab, imaging centers, and then some of them have urgent care and some of them have a freestanding ED. So those are a lot of the things that we're doing today. So we've had to set that clear direction a little more clear than maybe what folks they thought they had in the past. And how do we optimize it? We have to get to that consumer-centric, and we are doing that by clinical care redesign, and again, saving that $900 million over 5 years. So we've really shifted the way we think about it, of treating the illness, returning to health, and then sustaining that health. And how do we get that done? So we have a lot of retail pharmacies. We've opened up a couple of those. We have a specialty pharmacy that we just opened, and a lot of outpatient rehab areas, and home health, and many others. So we are looking at planning the patient's journey, and how do we do that efficiently and effectively, and from their perspective, not ours, because we may think that that's great, but when we ask the patient, it's not really what they want or what makes sense to them. So that's one of the areas that we're looking at. This is just a depiction of our clinical care redesign. So we looked at how do we go about changing the way we do our work and keeping it consistent. And so we have buckets. So care progression, care management, our clinical documentation, and our care variation. So all 4 of these buckets have big targets, and then the hospitals alone have their own targets that have to that roll up into that ultimate goal. Patient safety program. This is probably my favorite topic. I love patient safety. But it's amazing to me how long we've been talking about it. So 1966, I will admit, I was not alive then. But we've been talking about it a long time. And so how are we going to keep talking about it and not getting to improve? And so how many avoidable deaths in the U.S. hospital are happening in the hospital each year? What do you think? 100, 200,000. It's 200,000. It's a lot. So that's the equivalent of a 737 crashing every 7 hours. Would you fly? But yet we ask our patients to come to our hospitals every day. So it makes me wonder. Then in 16, we have medical error, the 3rd leading cause of death in the U.S. We had 05, there was a patient safety, healthcare was an airline, only dedicated risk takers, thrill seekers, and those living would fly on it. But yet we ask our patients to come to our hospitals every day. So what is the role of culture? So we have the final shuttle report, cites broken safety culture. We have this one, we have this. What's the commonality? It really is about culture. We can sit and put the best practices, the best technology, the best people in place, but if our culture doesn't meet that, it doesn't really do us a whole lot of good because they're not willing to do what's right for the patient every time, every day. So we have a serious safety event program. I'm going to flip through these fairly quickly, but we look at every serious safety event that happens in our organization. We have a 4-hour call monthly that we review every single serious safety event, including the ones that happen in our clinics, in our ambulatory space, and we evaluate them for scoring, number 1, to make sure that we're scoring them appropriately, and 2, what are the learnings from it? Is there a process that can be shared across our organization, or was it very specific to a hospital? And so we look at all of this throughout, again, the continuum of our organization. We have hospital filter committees is where it starts, and then it goes into our system risk call that's 4 hours every month. It's a lot to review. We have review processes like I'm sure everybody does. We apply those learning system-wide, so we produce a document after the system committee that has an ongoing action plan. It tells you where you are. It stays on there until it's complete, and those are anything that would take more than 30 days to complete. And then we have what we call our quick wins, or what do you need to know now, and those are presented at the hospital that tells the hospital, hey, you need to go look at this policy and evaluate if you're meeting it, or if there was a check for have you implemented the new Foley kit, is that complete? So it's those things that they can go and check, and then they are responsible for reporting back to us whether that was accomplished or not. We have a very detailed algorithm that we go through to look at these serious safety events. It takes a lot into account, so it's very systematic. We have levels of harm from SSE1, which is death, all the way to just a non-safety event, but it was a near miss. So those are all the codes that we use, and we trend those over time. We do produce this, we call it our cloud, and these are all of the serious safety events that happened for a month, for that particular month. The red means that was a death. The blue, if there were blue, it would be an SSE2, which is permanent harm, and this is also what's reported to our board. We put a name, an age, and what happened to them to make it real. I have seen other organizations utilize this, and they actually use a gravestone actually for their SSE1s that we did harm for a patient. So we really want to make it that this was a person. It wasn't just a number. We, again, do a lot of registry reporting. Again, a lot chest pain, STS, NSQIP, bariatric. And then why do we participate? Our physicians are very invested into this. They like the registries. We look at all of our data that we get, because we get a lot of data. We have converted almost all of our quality reporting, including registry, into a Tableau dashboards that are all, you can access them on our website, our internal website, if you have the correct access, because a lot of it is physician specific as well. They can drill down into their own data, which is nice. We have accountable care organization projects related to registries. A lot of our performance improvement in the clinical practice councils are driven by registry data. And so a lot of what we do is built off of data and registry information specifically. So a lot of data, as I could say. Total FTEs right now actually are 24 and a half FTEs that manage this. We were the very first ones to centralize our registry specifically for NSQIP, actually. And so we have a lot less staff reviewing and abstracting all of this data than probably a lot of organizations, because we have centralized the FTEs to do it consistently. We have a very robust process where we do inter-rater reliability. These are some examples of our dashboards that we produce. And just a cloud of words that kind of depict that it's quality data information, a lot of about health, community. So it's a lot of data. Can I say that every physician goes to their data and looks at it? No, we're still working on that. They really ask for it. When we give it to them, they either don't use it or don't want to go and look at it. So that is our next challenge, is because we do have a lot of information, but what we're finding is that maybe people don't really know what to do with that information. So we really call it about, we say that we are data-rich, information poor, is really what's happened, because we're able to get so much out to people, but what do they really know what to do with it? I've already kind of talked about the board structure. The delegation, we have MHMD, the CPCs have been delegated to look at protocols, performance products, payments projects, and then our program rationalization. And again, it is all based on best practice. And so this is kind of how it works. It's the critical care. All of these CPCs roll up to our MHMD board. So that's a separate board for specifically for the physician organization. And then that rolls up into our system board. And then back down to the MECs. The MEC has to approve all recommendations that come out of our CPCs. So the physicians on the ground still have to see what's being presented and approve it. If it is a required approval or a required task, and they decide not to approve it at the MEC level, they actually have to come to the board and explain why. Because it usually is based on best practice, something that is felt very strongly about, and so that has only happened a couple, probably in the beginning it happened more than not, but now we really don't see that happening anymore. So we look at publicly reports, consumer reports. There's a lot of stuff out there. So a lot of STS has probably been in the forefront here. They've been reporting for quite some time. And so there are more that are starting. PCI is starting to report publicly, and there are more that are planning to do so anytime once they get that approved. It's moving quickly all of a sudden. But if you're interested, a lot of these slides going forward are for your edification and really looking at, you don't have to do it now, but going to some of these websites and looking things up. This is really for what the STS public reporting, what the measures are. If you are a CV surgeon, you can actually go in and look at your own data. And they do look at it across the country. They benchmark you. STS star reports come out of this. This is actually what the public sees when they go onto that website. Doesn't probably mean a whole lot to them, but our public is getting smarter and smarter, and they are looking at a lot of information. I'm sure you've heard in the news now that they are starting to shop for care. There's been stories out there that people are flying across the country to get their procedures done at different hospitals because they have better outcomes. So we have to, as an organization, get smarter as well and really focus where we need to. Consumer reports. Everybody's probably familiar with this. If you want to go look for a microwave, I don't know, refrigerator, lawnmower, something. But guess what? There's health on here as well now. And so you can actually type in heart, and guess what? Heart surgeon ratings and heart rate monitors come up. So there's a lot of information, not all of it correct. I'm sure you're very well aware of that. But just know that there's a lot of information that our consumers are getting to, and making sure that you're aware and that your physicians are aware that there's a lot of information. We do this presentation for our physicians as well, and I can't tell you how many are like, well, I didn't tell them they could put that out there. We're like, well, they didn't ask you. They're pulling what they can, and they're going to put it out on the web for people to look at. So right between this was the funny part. So right between heart surgery and how we rate our heart surgery groups, you could also look at your bidet seat if you would like. So, it's interesting what comes up when you type it in. So we have PACMA, which is our phase of care mortality analysis. This isn't specific to us. We just take it very seriously. So any mortality that happens in our CV world, they actually get a review, and it looks at a lot of information. It comes out a little bit later in the presentation. But clinical experts, our physicians are so important to the care that's provided and to our leadership. We need the leadership of our physicians, and we have really embraced that at Memorial Hermann to really push us forward, because we're not going to get there without physicians, nursing, and we have to start listening to our frontline folks to move forward. We need them to be champions for the specific causes. We have a lot of physician champions that we utilize. They sponsor a lot of our performance improvement projects, and then they really are that captain of the ship at that moment in time. So it's a lot to do, and I would say that physicians coming right out of school, they actually don't get a lot of this education. So how do we get them there and comfortable with being able to get to that leadership position? So again, we have to define and measure. We have to look at our champions, and then we have to give them the education, the RPI, and guidance. The data is so big, and how do we understand it? We have to have that trust and reliability, which I think is the hardest thing to get a lot of times, and that goes beyond just physicians. Just in general, we have to get there. Team and support, the nurses and the frontline staff, if they don't believe in what we're doing, they're not going to help us along either. So the roles and relationships, private practitioners. So in Texas, we have still a lot of private practitioners. So not only our physician organization, our ACO members, our employed physicians, but we have a lot of private practitioners still today. And so we have to really balance how we implement a lot of our strategies across all those different groups. The culture, I've talked about that a lot. What's our strategic vision and direction, and it really starts at the top, and we have to push that down, and that starts with our physician leaders as well, and really being that change management person for the physicians to effectively change things in the hospital. So we've had a lot of registry achievements. I'm not going to spend a lot of time on that. Reimbursement-based, patient safety, transparency is big. Of course, if you've listened to a lot of the news lately about transparency. Rules about data, they're very significant. There's a lot of things that we have to measure and report out. We are getting penalty after penalty. If you look at value-based purchasing, if you're looking at our 5-star, that just impacts our consumer picture, what they think of us, and so we have to look at all of this. So CMS in 2005 published the Hospital Compare. They have been for several years now really pushing that physician compare. There is stuff out on physician compare now. It's not as much as they probably originally wanted it to, but I think it's going to get there. As soon as they can start getting that physician-specific information, the data will get published, just like on hospital compare. So Medicare.gov shows you can type in your zip code, you can look up your patient or the hospitals and the care provided. I will tell you right now, there's lawsuits where the lawyers are actually going out and getting all of this information and then bringing it back for different cases. So it is out there, and it's getting a little bit better on the time frame. So right now there are some things that are published first quarter of 18, which is pretty good for CMS. It's usually about 2 to 3 years behind. Health grades is out there too. You need to look at that. We measure a lot, and so, but if we didn't measure things, we wouldn't know how good we were at measuring the things we are measuring. Does that confuse you? We measure a lot of information. And so we have to just take it in pieces and what's important to the program, to you, to your patients, and really looking at that. I'm just giving a lot of resources out there. You can go to a lot of these programs if you can't sleep. These are really good documents to help you. There's a lot of rules. They come out every year with different things, and so there's a lot of things that we have to keep up with, and what you guys have to keep up with as leaders and just as physicians. There's a lot of incentive programs out there. We report about 215 different quality measures to regulatory bodies. And although they keep saying they're going to decrease the data required, they're talking about the abstracted pieces where somebody actually has to get into the medical record and look at it. And today, they are just switching those over to the billing data, the things that just come to them through the bills, Medicare specifically. And so I can't say that all the measures are great. If anybody's familiar with the new core measure for sepsis, it's horrible. It doesn't make sense. Nobody's doing well on it unless they're figured out a way to get everything documented. And so the measure development is is a huge piece. So they did have meaningful use that came out a while ago. For 19, it's gotten even, we're moving along in the journey. So they're trying to not duplicate measures that occur across multiple quality programs. They've never really talked before, and they would have similar measures but not the same definition. So you were kind of shooting in the wind of where you're going to land as far as compliance was concerned. They're trying to eliminate the measures that don't meet initiative criteria. Again, they're trying to align. And then they're looking at CMS assessment of inpatient quality programs for measure gaps. So there are 3 types. There's structural, process, and outcome measures that we look at. Obviously, structural is just, do you participate? Processes, is it a process? It's like the core measures. Did you give your beta blocker? And then outcomes is obviously what it says. It's how the care and how did the patient do after the care was provided. So there's the cost and resources efficiency. There's a lot of things that go into the type of quality measures. And capturing all of this, again, there's the ECQM, abstraction, there's claims codes, there's a lot of different ways. They're starting to do hybrid measures where they're doing a little bit of claims and a little bit of clinical data as well. These are just starting, and they're trying to build more of these. And sometimes people feel like this is what CMS looks like when they're trying to develop measures. Sometimes I've thought that because I'm like, where did they come up with this? But I would say just recently we've actually gotten into the last 2 years in some liaison work with CMS, Mathematica, which is a third party that works with CMS. We have 3 people that sit on NQF, different groups, and they are actually starting to work with them on measure development, and we have been a pilot for 3 of the measures the last 2 years. Some things on opioid, pain management, and then I think the last one was, I don't remember what it was. Anyways, it was that we were starting to be the pilot site. So it is really important if you have that opportunity to become liaison with a lot of these groups. It's important to do so. So sepsis, again, this was that core measure that I don't love, but there was a lot going on with this. It's been in the works since 2002, and then they adopted it in 2014, and it's taken a little while to take off, but it's ongoing revisions. I wish they would revision it out completely, but we'll see. Again, a lot of resources for you. There's Quality Forum. There's the CMS, CMIT public list of measures if you want to go and look at what's out there. Of course, then there's MACRA, AMP, MIPS, everything that we completely understand. I know Dr. Love is going to talk a little bit about that. And then we have the Reauthorization Act, the MACRA, and looking at that because there's the merit-based and then there's the advanced payment. We actually do not do the APMs in our ACO currently. We are still MIPS. Lots of scoring, quality. This is, again, resources for you if you want to look at all of this. It's a lot of information to take in a very short period of time, but looking at how you can get bonus points. If you're in a big group, it's usually easier. If you're independent and by yourself, this could be very overwhelming. There's some resources out there for MIPS, and then we would like to say this, but I don't think it's going away. Sorry. They just are going to continue to figure out. And really, I would love to say that this is about the patient care and that we want to provide good care, but no, they're just trying to get money back. Y'all realize that, right? It's not about the patient. They really are just they are taking penalty after penalty. So again, lots of just resources. That was really for you to be able to have that in case you couldn't sleep and wanted to go review something. Okay, that's all I have. Did I make it?